Welcome to COVID-19 Rounds. I'm Dr. James Gertson, the Associate Dean of CPD at NOSM. I'm located in Thunder Bay this afternoon, and we're looking forward to a wonderful discussion this afternoon on COVID-19 and respiratory disease. I'd first like to, while you are just joining us, to give you a little bit of an update on our webpage. And so when you came in today for the COVID-19 rounds, I pointed out a few things to you. This is your evaluation link, where you'll be able to evaluate the session today. And by evaluating the session, you give us your name and email address, and you will receive study credits, which we will look after. The other thing is, if you'd like to see the slide set that we'll be using today, once the rounds are finished, the slide set can be easily located here. And then finally, I'd like to just take you to our NOSM COVID-19 website, where the resources are also located. And just giving you an update on what's happening in Northern Ontario. As of 11 o'clock this morning, we have 183 COVID-19 cases that have been confirmed. There obviously are many more presumptive cases in the north. We continue to see a fairly large outbreak in Timmins, with close to 49 patients who are COVID positive. And then you can see also that we've got patients COVID positive in our two health sciences centers. Timmins, Sudbury, and Thunder Bay all have patients who are on ventilators in their ICUs. On our website, you'll see other good resources for you in terms of guidelines, critical care skills. Have a chance to have a good look at that to give you an update on COVID-19 resources, which are refreshed on a very regular basis. Our planning committee has no sponsorship or conflicts of interest to confirm to you. And we really need to emphasize that COVID-19 is rapidly changing. The knowledge is changing almost daily to weekly. Our presenters will be giving you the best currently available information, but realize that what was thought to be known a month ago may not be our present understanding of COVID-19. If you have questions this afternoon, please send them via the chat feature in WebEx, and we'll be recording those questions so that we can share them with our presenters. And finally, if you are on the phone lines, you can forward a question via our CPD email address. And as we've mentioned, as you came in, please keep your computers on mute. And we would encourage you to not transmit your images, as that will give you a better view of the slide set that we'll be transmitting back to you. It's my pleasure to introduce Barubi Beeman. Barubi is both a friend and a colleague here in Thunder Bay. Barubi will be our moderator for the session today. Barubi is a respirologist in Thunder Bay, and she's passionate about teaching both at the undergrad and postgraduate level. I'll turn it over to you, Barubi, to introduce yourself a little further, but more importantly, introduce Curtis.
Thank you very much, James. Can everybody hear me? James, am I?
Yes.
Perfect, thank you. So it is my pleasure. Thank you very much, Dr. Gertson, for this and for the opportunity to moderate these rounds. So I would like to extend a very warm welcome to Dr. Curtis Addison, who is actually one of ours. Dr. Addison actually is from Manitoulin Island, did an undergrad degree in chemistry at Western, formerly University of Western Ontario. Subsequently was at NOSM for undergrad and also for a residency in internal medicine. And after that, Dr. Addison found his passion in respirology, went back to Western, completed his fellowship in respirology, and is now doing an additional fellowship in advanced bronchoscopy and pleural disease. With that, Dr. Addison will be joining the faculty at HSN in January of 2021. in order to practice respirology. So I would like to extend a very warm welcome to Dr. Addison.
Thank you so much, Dr. Beeman. I appreciate that introduction, and it's a privilege to be speaking here at the weekly COVID-19 rounds through NOSM. Am I able to have the slides shared at this point? Wonderful. So I titled this talk, Respiratory Care in the North Amidst the Pandemic. And the reason for that is I want to touch on a couple aspects. This is really going to be a respirology perspective on COVID-19. I'm going to talk a lot about COVID-19 itself, but I also want to touch on really how to manage patients with other respiratory diseases in the context of the pandemic. So balancing the desire to avoid excessive healthcare contacts for patients and potential exposures, balancing that with providing excellent respiratory care. This photo here is from my hometown, Gorbea on Manitoulin Island. So just every opportunity I get to brag about my roots, I like to do that. So I'm northern born, and it's a privilege to be coming back to Northern Ontario next year. Next slide. I have no conflicts of interest to declare. Next slide. This is a bit of an overview about of the talk. We'll talk about the COVID-19 differential. We'll talk about clinical presentation, imaging findings. We'll talk about respiratory supportive care, specific treatments or investigational treatments that have been looked at for COVID-19. And finally, we'll talk about some of the non-coronavirus lung disease and how to go about managing that in the context of a pandemic. With the latter aspect of the talk, I'm going to try to focus as much as I can on points or ideas that would be specific to northern and rural treatment or practice locations. Next slide. This paradigm of the purist versus pragmatist approach, I just want to bring up. We're in a really interesting and challenging time right now. As much as we like to, with the emphasis on evidence-based medicine, we like to really present academic rounds that are focused on strong evidence, randomized controlled trials. And I want to do that as much as I can for what's available here today. At the same time, I do not want to miss an opportunity to provide some practical ideas for areas where there really isn't evidence. So I think that these two ends of the paradigm don't need to be thought of as extremes, but can coexist. Next slide. In terms of respiratory symptoms, I put the slide up just to emphasize that there's really only about 6 respiratory symptoms. There's not a whole lot of individual specific symptoms that will guide you in terms of one diagnosis or the rest. However, the fine details with each of these symptoms are important. At the same time, respiratory conditions often present with constitutional or other features, or conditions may be part of a multi-system disorder. But this is really what we have as a basis for respiratory symptoms. Next slide. The differential, on the other hand, is extremely broad for patients presenting with respiratory symptoms. Most of these are categories of diseases, and so if we start breaking these down into individual conditions, we're getting up into the hundreds of conditions here. So when a patient comes in with fever and cough, really it's a very difficult situation. None of these things are specific to COVID-19, and especially in the context where we're trying to sort out the evidence and don't have any proven therapies to date for COVID-19, really want to be careful that there's a careful search for other associated conditions or conditions that could be present alongside COVID-19 infection. So this is just a brief list of some of those other conditions or categories. Next slide. This is data from a study from China published in the JAMA, which looked at a number of presenting characteristics. So this patient population specifically is patients with confirmed COVID-19 pneumonia. So all of these patients had radiographic opacities, and all of these patients were admitted to hospital. In that patient population, and all of these symptoms are what they presented to hospital with. The vast majority of patients with COVID-19 pneumonia requiring admission had fever and cough. Now, Other symptoms, constitutional symptoms were present with decreasing frequency. Notice that dyspnea was present in just under a third of patients at presentation. And a number of patients, a small portion of patients had GI symptoms. Breaking this down and using some data from other studies, there are some patients that present with only GI symptoms, although this is a vast minority. Go to the next slide. This is that same data for SARS coronavirus 2. So that same study, and overlaid as best as I could with some older data from a study that looked at presenting features for patients with H1N1 and seasonal influenza A pneumonia. So the 2019 H1N1 data is compared there with the previous 6 years of influenza A pneumonia admissions. So not all of these categories line up perfectly, but you'll notice that the most common presenting features are similar between SARS coronavirus 2 and H1N1. Vast majority of patients with pneumonia present with fever and cough. Looking down at the list, one major difference is that these other infections, viral infections, had a much higher prevalence of dyspnea at presentation. And keep in mind, this is presenting data. So as patients got further in the course, and patients with more severe disease, the prevalence of dyspnea and some of the constitutional symptoms went up quite dramatically. Next slide. This was a significant area of interest amongst our respiratory group here in London right now, and in the literature. Lab values, there was some consideration that some of these values might be very predictive and helpful early on, especially when COVID-19 testing access was limited, or the delay in turnaround times was greater. Most patients presented, or the average white blood cell count was normal. About half the patients were higher or lower than the reference range, and not dramatically so. The lymphocyte count was particularly interesting. This tended to be low in the majority of patients, even at presentation. It tended to be lower in patients that required critical care admission as well. Albumin levels tended to be slightly low. You can think of that as a negative acute phase reactant. Troponin I levels, this is actually based on a high sensitivity assay, but it did tend to be normal in the majority of patients. It tended to be a bit higher in patients that required critical care admission during that admission. LDH tended to be mildly elevated, and again, higher in patients that required critical care admission. And interestingly, the procalcitonin level, and for those that might be not as familiar, this is an analyte study that's thought to help us differentiate bacterial from viral pneumonias. And that didn't really seem to be the case here. So there isn't rigorous data that allows us to say that none of these patients had bacterial pneumonia as well. But at least in terms of this study population, actually the majority of patients had a high procalcitonin. So it may not be that this is helpful in that viral versus bacterial question for COVID-19. But I'll get into some things that are more helpful. So next slide. This is a different study looking at diagnostic imaging characteristics of COVID-19. And so these are patients that were admitted to hospital for COVID-19 infection. This population actually includes patients that didn't actually have airspace or pulmonary parenchymal opacities, so not necessarily COVID pneumonia, but patients requiring admission. And looking at this list, the majority of patients that required admission did have opacities. They tended to have either ground glass or a mix of consolidation and ground glass. So if you add those two categories together, that's 75% of patients had those features. Bilateral opacities of the patients that did have lung findings were present in over 3/4 of patients, 77% of patients. Interestingly, this idea of rounded opacities, which I'll show, was present in more than half of patients. And this is perhaps a feature that is somewhat, or seems to be somewhat more specific to this population. Peripheral distribution is present in just over half of patients, with the other half having no particular pattern of distribution. Next slide. These are features that are that weren't or very infrequently described in this population. So patients presenting with consolidation without any ground glass was infrequent. None of the patients had cavitation, a peribronchovascular distribution. I'm kind of getting into detailed radiology here, but that basically is disease that's in the lung that is centered around the larger blood vessels and larger airways, as opposed to the periphery of the lung. Interestingly, patients infrequently had underlying emphysema, which is interesting. Similarly, pulmonary fibrosis was not described in this study, and virtually no pleural effusions and no nodules for lymphadenopathy were seen in this study. So the take home here is that any of these features really should prompt consideration of an alternate diagnosis. Or even if a patient has confirmed COVID disease, I wouldn't readily attribute any of these features to COVID-19, but rather suspect a second process is going on. Next slide. This is just an example to highlight some of those imaging findings. On the left is an X-ray of a patient with right lower lobe airspace disease. Basically, dense opacification, there's obscuration of the diaphragm, and it might not come across in the screen as well, but there are air bronchograms. Looking at the right, this would be the CT scan correlate to that finding, in this case bilaterally. But you'll notice that there is density in the lung that is so dense that it obscures the blood vessels. You can't pick out this branching pattern of blood vessels amongst that disease. And also the air bronchograms are highlighted quite nicely in this picture. So that's what we're talking about when we're talking about consolidation. In this image, there's really almost zero ground glass opacity. And so that finding would be suggestive of another diagnosis. Next slide. In contrast, this would be a CT scan that shows ground glass opacification. And so this is a density in the lung that is greater than normal, kind of a gray haze appearance that you see in the center of the lung here. But you'll notice that even amongst that abnormality, you can see blood vessels branching quite nicely within that space. So this is what we talk about when we, or what we're meaning when we talk about ground glass opacities. So patients can certainly present with only ground glass opacities with COVID-19. Next slide. This is that interesting rounded opacity that's described in the study. This is an image from that same paper. And so these tend to be fairly large nodules, multiple nodules of ground glass density, but they're quite rounded. And this is not a common feature of other viral pneumonias. It's hard to know right now how much specificity that would have for COVID-19, but it's certainly an area of interest that's being studied right now. Interestingly, the radiology world has come up with a CORADS, or in other words, a scoring system for features that are thought to relate to COVID-19. And that's going to be an interesting area of study down the road. Next slide. I'll talk a bit about respiratory supportive care. So these are different methods of delivering oxygen for hypoxemia. Hypoxemia is probably going to be the major challenge for most patients with COVID-19 pneumonia. Another story when we get into ARDS as a complication. But as you can see here, this sort of outlines an approach to increasing oxygen delivery. Starting with nasal cannula, the limitations there are that once you get up to about 6 liters per minute at most, it's generally poorly tolerated with nasal drying, and we need to step up the therapy to something else. Face masks allow a higher concentration of oxygen. There's a major challenge with these devices in the sense that although we can kind of estimate an average amount of FiO2, or fraction of expired oxygen for patients getting this type of oxygen, this number actually dramatically varies depending on the patient's peak inspiratory flow. So when respiratory efforts or distress is present, the amount of oxygen delivery might actually decrease significantly. And we really don't know what that number is going to be at any given time. The way to get around that is an air entrainment mask. So this allows us to have a little bit more precision with the amount of oxygen that's being delivered. This is commonly known as the Venturi system, is commonly known in local hospitals. So with this, we can deliver up to about 60% FiO2, but we can do it with a little bit more precision. Following that, we can go up to higher concentrations with a non-rebreather mask. Often you hear about 100% non-rebreather. There's always going to be some air entrained unless you have a closed system. But with a non-rebreather, you can probably deliver in excess of 90% FiO2. The remainder of the systems here, I've highlighted in red. These are more aggressive or higher supportive measures, but all of these are considered aerosol generating medical procedures. So with any of the next four measures, it's important to note that the recommendation would be, if available, these patients should be under negative pressure isolation. Healthcare providers in the vicinity should be wearing N95 masks, and there should be droplet and contact precautions in addition to that as usual. High-flow nasal cannula is an excellent delivery system for patients that are hypoxemic but not requiring support with ventilation or CO2 clearance. This allows us to deliver a very high concentration of oxygen through a nasal cannula, which is heated and humidified to optimize comfort. The idea here is that there's a very high oxygen flow, and when patients take a deep breath in, we're actually able to deliver a jet that is fast enough to allow most of that, or almost exclusively all of that mixture to be coming from the system, so with minimal air mixing. Patients do need to have a patent nasal cavity for this to work, but this is a very comfortable method for oxygen support at a high level for a long period of time. Beyond that, we start to get into the non-invasive methods of ventilation, or CPAP to begin with can be a way of supporting oxygenation without ventilation. And then similarly, non-invasive ventilation, or BiPAP. And I'll talk about this a little bit because this is a bit of an area of interest, especially as it relates to COVID-19. And then finally, invasive mechanical ventilation. Once you proceed to this degree of support, you now have a closed system, which is desirable, but at the same time, the act of intubating a patient is a significant aerosol generating procedure with potential for exposure of healthcare providers. How to go about managing these and how to transition from one to the other is a very complicated topic, but I'll give some pointers in the next few slides here. So next slide. So talking about non-invasive ventilation, or BiPAP, there are a number of conditions that have very, very strong evidence, especially the top two here: acute exacerbations of COPD and cardiogenic pulmonary edema. These are conditions that have been studied and looked at in Cochrane systematic reviews, and have established mortality benefits and reduced rates of intubation. I mention that because there's a lot of concern or hesitation around using some of these interventions in the setting of the current pandemic. Different centers are adopting different policies on how to go about this, and I think it does have to be individual and take into account the local resources and ability for infection control, the various practice locations. Having said that, we'll go to the next slide here. This is a different way of framing contraindications to non-invasive ventilation that perhaps I don't know if is ever described this way by anybody else, but this is the way that I really like to think about it. I would argue that there's only one true contraindication to non-invasive ventilation, which is need for emergent intubation. The reason I like to frame it like that is that if a patient is in a degree of respiratory failure where they require non-invasive ventilation, but there's a reason not to do it, that patient is not going to be well served by doing nothing instead. That patient is really going to need a higher level support, as long as it's consistent with their goals of care, their resuscitation status. But that patient is going to need to be intubated. And here's the list of those conditions. So they've had an arrest, they can't protect their airway, severely impaired consciousness, or they can't cooperate, clear secretions, and so on. So that's the traditional list of contraindications, but framed in a different way. Next slide. Other aspects of respiratory supportive care that I'll touch on. For patients that are presenting with bronchospasm, salbutamol, ipratropium can be used as bronchodilators, but it's recommended that we try to use MDIs. The Nebulizers are considered aerosol generating and maybe an infection control parameter that might be worked around. In patients that are able to take MDIs, the evidence suggests that they're just as good. But patients that do require non-invasive ventilation, these can actually be delivered through the system. So without having to take the BiPAP mask on and off, these can actually be delivered in line. In terms of other aspects, it's important to identify and treat underlying causes. So if the patient has a clinical presentation consistent with exacerbation of asthma or COPD, these are patients that would benefit from administration of steroids or antibiotics as you normally would, even if the exacerbation is triggered by COVID or coronavirus. Identifying aspiration and making appropriate lifestyle modification and treating esophageal disease is another important aspect. So all of these things should be considered in the context of the current pandemic. Next slide. In terms of ARDS, this is easily a 3-hour lecture. But just to summarize that ARDS management in COVID-19 is generally quite similar to ARDS from other pulmonary causes. So a lot of the main or key features would be that we deliver lung protective ventilation. The ARDSnet website has a number of resources and a protocol for how to match PEEP to FiO2 and how to choose ventilator settings. Neuromuscular blockade and proning for more severe patients is a consideration. Trying to conservatively manage fluid where appropriate, prevent hypervolemia, and treating complications such as ventilator-associated pneumonia, for example, bacterial pneumonia. Next slide. Specific treatments have been a huge media area of interest, and I'll touch on this a little bit, but below are a list of investigational treatments. And this isn't completely exclusive, but these are some of the main ones that I looked into. Next slide. This is a summary of the evidence that's available in published reports for these treatments. So hydroxychloroquine and azithromycin are a big area of interest. A lot of these treatments, you'll notice, are based on animal data. For hydroxychloroquine, a small RCT and a non-randomized trial. I'll note that there's a lot of criticisms about these two studies that I've cited here. The references are available at the within the slides that you can download later. But there's a lot of criticism about the methodology in these reports. So what we really lack is our RCT data that show significant patient-oriented improvement for any of these treatments. There was an RCT that's published for lopinavir ritonavir, which is a HIV medication, combined protease inhibitors. Now this did show a trend towards improved mortality and a change in time to clinical improvements. So I tend to think of mortality trends, even if they're not statistically significant, as being an area of interest to pay very close attention to, but there's nothing that we can definitively say has proven benefits. Next slide. Just actually on that last point, I will mention that a number of the organizations, the Infectious Disease Society of America, the Canadian Critical Care Society, Public Health Agency of Canada, all of these organizations have recommended that any of these investigational treatments be delivered in the context of a clinical trial. Health Canada actually has a list of these ongoing clinical trials that are approved by Health Canada. Looking at the list, the inclusion criteria wasn't always described in terms of location, but I couldn't find any that were specific to or that would be accessible for patients in Northern Ontario. That'll be an evolving situation and maybe a website to pay close attention to. So in terms of some pointers to help reduce healthcare-related exposures, but still deliver quality patient care, I'll give you some strategies with respect to airway disease and pleural disease and try to help balance that idea of providing good care with good infection control. Next slide. For asthma, what I find is that a lot of the data that helps you in asthma to manage patients that have a pre-existing diagnosis is readily available by history taking. You want to know if the disease is controlled. You want to know if the patient is avoiding triggers. This includes smoking cessation. And you want to make sure they're comfortable with the use of their medications and they're using them appropriately. All these things can be asked, or ideally, if you can actually use video to assist with things like inhaler technique, you can provide a lot of really good follow-up care for these patients. Below is a table of the criteria for asthma control as it's presented in the Canadian asthma guidelines. So most of these features are historical. Note that FEV1 there is one of the criteria. However, if patients are interested in monitoring their lung function, who have good control of their symptoms otherwise, an alternative option would be to have them consider getting a peak flow meter. And this is something where they can have anything from an analog meter that can be purchased for low cost to fancier devices that actually measure peak flow and FEV1. So for those patients that are really keen on optimizing their management and have good symptom control, that's an option. Next slide. For COPD, a number of the key features, again, are historical. It's important to characterize the patient's dyspnea, especially using a standardized score which relates to or helps to describe their exercise tolerance. Whether the patient's having exacerbations and their frequency and severity. Are they producing purulent sputum, and have they achieved smoking cessation? And depending on the patient, their comorbidities, and so on, a goals of care discussion and resuscitation status would be important to identify in a lot of these patients. To the right are the Canadian guidelines, the COPD guidelines for treatments of COPD. And so you'll notice that this paradigm really revolves around symptoms and exacerbations. And this gives you a rough guide to how to adjust therapies based on those parameters. Next slide. A lot of this is a controversial slide, I should mention. I probably wouldn't recommend referencing this in any Royal College exam. But in terms of the physical exam on a regular follow-up of an airway disease patient, I don't tend to find that a lot of these things add a lot of clinical value on top of the history and on top of self-monitoring of lung function if they're doing that. A couple of the specific features that would dramatically change approach or investigations would be if the patient's hypoxemic, if they have clubbing. So clubbing is not a feature of COPD, but rather reflects some other process such as chronic hypoxemia or lung cancer. If they have lymphadenopathy or if they have volume overload. And I've kind of listed the potential actions that could be taken if these are identified. Next slide. So this is a very pragmatist and non-evidence-based approach, but can you actually try to address some of these findings by history? If a patient is interested, perhaps you could do self-monitoring with a personal oximeter. This is also frequently done via programs through home care or COPD clinics or programs. If a patient has noticed nail changes or new lumps or bumps that could represent lymphadenopathy, if the patient notices volume overload, and a little bit of careful description about what they can actually find with pitting, because patients don't tend to always notice lower extremity edema. This might help to bring out some of those symptoms. Next slide. I should mention that any of those concerning findings, when they do show up, may help you triage and identify patients that need to be assessed in person. In terms of the site of care during the pandemic, ideally, if care is non-essential, we'd really like patients to be at home if possible. If care is to be done, I would suggest that there's perhaps less exposure risk in certain clinic settings, compared to the emergency department and then admission to an inpatient ward. So this is almost could represent a hierarchy of preferred location of care as long as it's safe to do so. Next slide. So I'll talk about a condition where I think there's a lot of opportunity to promote outpatient care. And although this is something where we're going to be looking at increased use of a clinic as a resource, This is something where we might potentially prevent ER admissions and hospitalizations. Overall, I would argue that this approach can almost certainly reduce potential patient exposures to coronavirus. The natural history of patients with malignant pleural effusions is to basically get worse. Most patients will have a progressive increase in their pleural effusion. They will become symptomatic at very different points or volumes of pleural fluid. But eventually, almost all patients, if their effusion continues to progress, will develop symptoms. Those symptoms will eventually bring them to clinic or to the emergency department. Once they're in the hospital system, the likely course is that they will have some intervention. And so the most minimal way of going about this would be performing thoracentesis. And if that's the case, the patient will usually get relief of their symptoms, but that will be typically short-lived. Some patients will have a long-term benefit, but the majority will have recurrent effusion and progressive dyspnea. There's a couple opportunities to intervene here. And the common and much longer used approach would be admission to hospital, chest tube insertion, and talc pleurodesis. This only works for patients that can actually have lung expansion. I'll talk about that in the next couple slides. But there's an alternate opportunity here to manage these patients potentially in clinic without ever coming into hospital, or if they do present to hospital, it can still be done. And what I'm talking about is insertion of an indwelling pleural catheter. So this patient population, because of the recurrent nature of their effusions, this is also a patient with, unless it's mesothelioma, any other cause of malignant effusion represents metastatic disease. So any opportunity to keep these patients in home, especially considering their poor prognosis and tendency to develop weakness in hospital, is really, really preferred. Next slide. This is an X-ray that demonstrates that concept of a non-expanding lung. And so what's happening here is that patients undergone thoracentesis. You get this appearance of a hydropneumothorax afterwards in the image on the right. Now, this does not always represent that air was entrained during the procedure or that the lung was punctured. But a common reason for this in the malignant population is that the lung is trapped behind an inflamed or a fibrotic pleural space, or pleura, which doesn't allow the lung to fully expand to the chest wall. And this is important because if you try to put a chest tube in and drain out all the fluid, this is going to be what the X-ray looks like. Now, sometimes you can get more expansion over time, but the majority of patients won't be able to expand their lung. The way that talc works is that it basically causes inflammation and kind of turns the pleural surfaces into glue, gets them to stick together. And so if you try to do that, but the lung doesn't expand, it's going to be completely ineffective. The same rate of adverse reactions is there with no benefit. So these patients need an alternate solution. Indwelling pleural catheters, on the other hand, can still be done and can be very effective for symptom management in patients that have non-expanding lung. Next slide. These are examples of pleural drainage systems, and I tried my best to include every brand that I could find. The rocket catheter and Pleurex catheter are the ones that I've seen used at some of the southern hospitals. The other systems are available as well, and all these are very similar. The idea here is that there's a catheter that's able to be tunneled through the skin. All of these have tunneling kits associated with them. And the idea is that you insert a chest tube, but with the addition of a tunnel that protects it from infection. This basically is meant to be connected periodically, as opposed to continuously through a Pleurovac system. And there are drainage bottles that are available through or with access kits, or some of them can use generic drainage bottles. The idea here, though, is that this is a treatment that can be delivered on an ongoing basis through home care nursing, nurses that are trained in the drainages, and allow for complete outpatient management of recurrent malignant pleural effusions. There are some other applications outside the malignant population, which becomes a bit more complicated. But I just want to bring up this approach in this setting where this population is often ideally managed out of hospital, and especially with the desire to avoid contacts this may be a really good option for these patients. This can be done in larger centers as well as in communities. In London, for example, a number of the smaller communities, nurses have been trained, home care nurses have been trained to deliver care for these systems, and it's been quite effective. Next slide. This is just a little bit of information that I want to include with that. I won't go into detail, but just comparing the different approaches to recurrent thoracentesis, tube and talc approach, and indwelling pleural catheters for management of infusion. So that's just an FYI associated with the other slides. Next slide. In terms of the take-home messages that I want to reinforce, keep in mind that the clinical presentation of COVID-19 is non-specific. Although what you really want to do with identifying these patients is use appropriate PPE and prevent transmission of disease. So I'm not advocating that we dismiss the concern about COVID-19 by any means, but rather consider it, protect against it, and then hunt for other diseases that could be causing these symptoms. There are no contraindications, no absolute contraindications for BiPAP, but rather there are a number of indications for emergent intubation. No specific COVID-19 treatments have demonstrated benefit in patient-centered outcomes so far. There are some unpublished data, and there are a number of clinical trials underway, and this is going to be an evolving situation. But so far, the data isn't there to support a recommendation of using these medications routinely in COVID-19 outside of a clinical trial. In terms of the care of respiratory patients, the benefit to providing care through phone or video conference, and through some of the strategies I mentioned. And outpatient interventions, such as the pleural catheter, can actually reduce ER visits and hospitalizations, and in turn actually reduce potential exposures to COVID-19. Thank you very much. So that's it for my presentation, and I'm happy to take a large number of questions.
Thank you very much, Dr. Addison. So the first question is, it's lengthy, but I'll summarize. There is a recommendation at my hospital from ICU and internal medicine to avoid physical exams, in particular respiratory exams, in probable or confirmed patients with COVID. Is this based on evidence that doing respiratory exams does not change the management of these patients? And there's a comment that this is counterintuitive for most of us. And is there evidence that only relying on vitals changes outcomes? And is there an approach is this an approach other centers are following?
So that's an excellent question. And, prior to all this, I was always a huge proponent of physical exams. The idea, I think, is being just a little bit more selective with exams. The approach at London Health Sciences Centre, in my experience, has been to pick and choose, to determine really what you're going to do. And instead of really doing exam aspects of the exam that are really focused on completeness, really look at what's needed for changing that patient's situation. So for example, we might forego something like a head to toe neurologic exam, a patient with no neurologic symptoms or complaints, but rather focus on a focused cardiorespiratory exam, and then mitigating the risk of exposure with things like having a stethoscope in the room for repeated use, and appropriate PPE. The conversation part can happen separate. So if the physical exam happens in the room, one of the things that they're doing in London is using a phone into the patient's room to gather a lot of the historical data. So, and I'm kind of talking around the question a little bit. I think it's not quite black and white. What I would suggest is a few strategies to try to minimize contact where possible, but where you identify issues and where you really have a physical finding where you think that it's going to change the management, that's an appropriate time to do this. But then there's ways that we can actually do that in a fairly quick fashion and limit exposure, as opposed to the kind of standard full head to toe exam that we often advocate and try to teach. So there was a question about evidence as well. I'm not aware of any evidence related to this topic, and I've tried to just make this really a disclaimer. It's a pragmatic approach in this setting.
Thank you. The next question is actually one that has come from the community. One is a lot of, chronic lung disease was underrepresented in the patients, the Wuhan cohort anyway, what's being reported. And how would you reconcile that with the increased risk? So there are some increased risk populations with hypertension and cardiovascular disease, and chronic lung disease is also part of that. So how do you sort of interpret those two differences?
It's really hard what to know about some of the data. It's interesting that there was a lot of interest initially on pre-existing diseases that patients were more susceptible to severe disease if they had these conditions. At the same time, like the radiology data I presented, vast minority of these patients had any structural lung disease that was there, even emphysema. So I think what I would take out of all that is that this is a disease that can affect, very different populations. I'd be concerned if a patient has underlying lung conditions or other systemic conditions. But I wouldn't be particularly reassured if a patient is otherwise completely healthy, because we are seeing examples, numerous examples of patients that had really no underlying lung disease and do present with severe disease or develop severe disease.
Next question, I think Dr. Gertson has a question.
Question for either Dr. Beeman or Dr. Addison. What do we know about young patients that are moving toward, young patients with COVID that then go on to get severe respiratory disease ventilation? I think we have this idea that the individuals that will get severe disease all have risk factors and we can identify them early. But certainly, as I listen and look at what's happening, we certainly have young, healthy people going on to very severe lung disease. Do we have any explanations for that?
So I can get that if you like. So right now, Dr. Gertson, there actually is no good data to, we hear about anecdotal reports and some case series about young individuals being afflicted, but we actually don't know enough about the individual patients. We know there are some factors which are poor prognostic factors, and they tend to be age. So age is one of them, but it's also chronicity and chronic disease. We've identified a couple: hypertension, cardiovascular disease, chronic lung disease, but there's also immunodeficiencies, which are less frequently diagnosed and often undiagnosed in certain populations, or specific other factors, which in the Wuhan cohort was seen to be obesity, BMI greater than 24, and smoking was actually also poor prognostic risk factor. So we actually don't know enough about these young individuals. So more information is actually what's needed. And I don't know, Dr. Addison, if you wanted to add something to that.
So that echoes my thoughts on it as well. I think that initially we might have been falsely reassured, given some very, very early data on young patients. It certainly seems to be a decreased frequency in very young patients. But we can't be reassured that patients are not susceptible to very, very poor prognosis, even if they're very healthy to begin with and young.
So a question I have, Dr. Addison, is what do we know about? There's a lot of interest right now in asymptomatic transmission of disease and virulence. And so what is current thinking with regards to transmission for asymptomatic patients?
I think it's we're growing to know that this may have been a largely missed opportunity with our understanding of the disease early on. The degree based on some models of asymptomatic transmission varies quite a bit, but it's thought to be potentially up to 80% in certain populations. And so this clearly has a very important role in how the disease is spread. But because of its asymptomatic nature and the way that testing has been carried out early on and continues to be carried out, we really have so little information to go on with how many patients are actually infected and how it might spread.
Okay. Excellent, thank you. One other question that's come up. Do you have any experience with awake proning for COVID patients? So I think this would be relating to your experience at Western.
Sorry, I think I missed the keyword there. Experience with?
Awake proning for COVID patients.
The way that we've done things in London really has been to try to keep the intensive care and respirology settings completely separate with good communication between the teams. So that's really all been in the critical care area. We tend not to have consults that relate to management of COVID patients in the ICU, but rather patients that are sick and needing hospitalization and eventually will, may or may not require transfer at some point. Proning is very resource intensive, so it's a difficult thing to perform when resources are less. It may take 6 staff to prone a patient. And this is not a one-time endeavor. They're turned multiple times. So it really is resource intensive. But I think for patients that have severe ARDS, I would I would sort of consider this in the same fashion. Ideally, you'd like to avoid healthcare providers that are otherwise not being exposed to patients for these purposes.
Can I ask a question? For Dr. Addison, I was just wondering, I know we've sort of talked about the chronicity of lung disease as being an independent risk factor, but I wondered if there was any evidence to support asthma as an independent risk factor, or whether there was any research done into that as of yet.
I haven't seen a lot of good data on asthma specifically. With our experience with any other respiratory viruses, any of these viruses, other coronaviruses, we know can exacerbate asthma. And so I don't think I have a specific citation to relate to that. I'll see if Dr. Beeman might know of anything, but certainly we feel that controlling airway disease is the best, as best as possible prior to a patient becoming unwell is likely to be in their best interests. And preventing exacerbations in mission hospital, even through for non-COVID-19 reasons, is likely to reduce their risk of being infected when they're seeking healthcare as well. So it's strongly advised. Dr. Beeman, were you aware of any specific data on the asthma population?
Yeah, so as far with all the reading that I've done so far, asthma per se does not increase. Sorry, there's no evidence that asthma increases the risk of COVID infection. However, as Dr. Addison mentioned, anything that reduces control of asthma puts the patient at risk. The risk with chronic lung disease, I suspect, although it's not really been clarified by the literature, occurs if there's structural lung disease. And I'm extrapolating from other data from other infectious diseases, but generally with structural lung disease, we're talking about things like bronchiectasis or interstitial lung disease, or actually scarring of the airways or the parenchyma. So that is what actually confers increased risk. So as long as the underlying asthma or COPD are well controlled. So the other, this sort of leads us into the question about the use of inhaled corticosteroids, because that was thought to pose an issue with patients with COVID. We know with other coronaviruses, for instance, there is actually no benefit to systemic steroids, and there actually, of course, is the risk of side effects. And there was also in one study with MERS, I think, delayed clearance, MERS or influenza, I can't remember, delayed clearance of the virus. So as a result, steroids are not recommended unless they are needed for control of the initial underlying disease, for instance, asthma. So if the patient requires inhaled corticosteroids or systemic steroids for any other disease, then that's recommended. So I guess the objective is to actually control the underlying disease to avoid risk of exacerbation and COVID infection. So we do have another question. I hope that answers your question. There is another question, Dr. Addison. Are asymptomatic TB carrier patients at risk of reactivation of that disease with a COVID infection?
Not that I'm aware of. I haven't come across any evidence that suggests that. I did mention that initial list as one of the conditions I was concerned about in the sense that this may be a disease that we don't pick up as much because of some changes in culture and concern for infection control. So I think it's important to be vigilant and really consider that and ask a good history surrounding risk factors for tuberculosis. But I'm not aware of any risk of reactivation of TB because of COVID-19. Interestingly, biologically, the lymphopenia that can come about, could suggest a mechanism, but I'm not aware of any empiric data.
Thank you very much. I think it's also important to realize we may not have enough experience quite yet with a lot of these conditions, so we have to, it's also a wait and see. Next question. Can you explain the reason COVID-19 patients who are ventilated often require 10 to 14 days of support?
The natural history of more severe disease is to develop more severe pneumonia with hypoxemia. And then a number of these patients will have complications of ARDS. Unfortunately, as much as ventilation, intubation ventilation is needed to support these patients, there's often increased injury that happens as a result of the positive pressure that's delivered. And this is just a huge challenge. Why patients don't respond quicker? I think the conditions where there tends to be rapid response tend to be conditions where we can use really effective treatments to turn things around. So for example, in severe pneumonias, we may be able to turn things around more quickly. COPD exacerbations that require intubation, we tend to be able to treat that underlying disease quickly. So I think it reflects to the natural course. This is a virus that has a long natural infectious course. And for patients that have a severe presentation, there's nothing that we're doing specifically that's going to get at the underlying course. So it really has to run its lengthy infectious course.
Thank you. There are no other pending questions, so I actually have one for you. So a number of individuals, so we're all quite cognizant of the fact that a number of healthcare personnel have been infected and are subsequently having to self-isolate at home. So this goes along with the question of chronic lung disease. If you have a patient who is also, a healthcare personnel working in close proximity with COVID patients, particularly if they have something like uncontrolled asthma, would you ask them to remove themselves from that environment, or what would the precautions that they take have to be? Normally they would be at work.
I think always our best defense is going to be really strict adherence to preventative measures. But having said that, there's not going to be a method that specifically in the real world setting completely protects these individuals. I would recommend that if it's possible to avoid work until those conditions are better controlled. For example, if someone has severe asthma, that's a condition that in the vast majority of patients, we should be able to get them under control through stepwise management. So I think in the short term, if someone is working in close proximity, looking at tailored work, for example, some units are using hot and cold areas, so avoiding contact with specific COVID patients or high-risk patients, or even looking at work from home where possible would be advisable until the disease is under control.
Thanks so much, Drs. Beeman and Addison. It's Dr. Gertson. We're just going to be winding up our round session today. I'd like to really remind everyone, please complete your evaluation. It's on our COVID rounds site. Will take you all of 3 minutes, and will certainly give us valuable feedback in terms of future sessions, ideas for future sessions, and also give you study credits, which will be forwarding to you sometime in the future. Our session next week, April 24th, will be COVID-19 and the mental health impact. And our presenters will include Doctors Diane Whitney and Jack Haggerty and Ms. Stacy Rolls. Thanks so much for joining us this week for COVID-19 rounds. Please stay safe. Please ensure that you also look after yourself and your families. Thanks so much. We'll see you back next week, same time, Friday, April 24th, starting at 12:30. And a big thanks to our two presenters, Doctors Beeman and Addison, wishing everyone well until we see you again next week. Thank you. Curtis, thanks a lot. Really appreciate. Ruby, thanks a lot. We still are online.